PACOP Morning Tea Talk this fine February day. We would like to say thank you to Dr. Caroline Phelan, who's joining us today from the University of Flinders Uni in South Australia. And also to say hi to Nat, who's joining us from WA, Improvement Facilitator Extraordinary for PACOP. One of the things we just need to do to start the day, is an acknowledgement of country. So PACOP wishes to acknowledge the traditional custodians of the lands and the waterways that we're meeting on today. Always was and always will be Aboriginal land. We pay respect to elders past and present and to any First Nations people who are joining us today. So, Caroline, we're going to hand over to you, and then I think there's a few questions we'll probably ask you along the way. And there are some questions that may be coming through from the audience or the participants as well.
All right. Can everybody hear me okay? I'm sure you can. Yes, great. So, look, I'm going to talk a little bit about pain management today. My background, I worked in pain management for a long, long time. And so I'm quite interested. I actually did my PhD in pain management for older people. So I wanted to start today by just sort of reminding everybody that good pain management starts with thinking. And really we need to position ourselves around this idea of what sort of pain is this person in, what has worked, what is working, what hasn't worked, what happened last time I gave them some medication, or what happened last time they tried to move, and what is our goal for pain management? Are we trying to achieve improvement in function? Are we trying to achieve comfort? That sort of thing. Next slide, please. So it's important to think about how age impacts our ability to perceive pain and also our ability to modulate pain. So we know that as the brain ages, and this is a normal function of aging, it impacts on the way we think. It also changes the way we perceive different aspects of our life. And one of the really interesting things that happens is our spatial perception alters. So our likelihood of understanding a horizontal scale changes, and we're more likely to understand a vertical scale. So a thermometer is easier to look at and understand than something that's on a horizontal plane. Next slide, please. So we also know that the aging brain. Wait for this.
Sorry.
That's
Sorry.
next. So other things that change as we age. So this is a really interesting study. Vocabulary knowledge. So our language doesn't change very much as we age. Our reasoning ability does shift. Our spatial visualization, as I said, changes. Our memory, our ability to recall things reduces, and the speed at which our brain works does change and does slow. So all of those things impact on how we might assess pain and how we might assess other symptoms as well. So, for example, using vocabulary is much easier for an older person than using numbers or a numeric scale. So, which has impact, and our spatial visualization changes as well. Like I just mentioned, it might be easier to use a pain thermometer scale rather than a horizontal ruler. Next slide, please. So the changes of our brain influence the perception of pain, so the way we might perceive pain, but it might also change the way we manage pain. So older people may not process pain the same way as us very young people do. Oh, they're so young. So there's not much change at lower levels of a mild pain, but as pain becomes severe, older people will still sense it the same way, but their inhibitory control is lost as our nervous system changes. So essentially more difficult for an older person to cope with severe or persisting pain, which is why it's so incredibly important we assess it and then we manage it. Next slide, please. So what does this all mean in practical sense? So there's some really good evidence that the pain thermometer is useful for older people, and that is a universal tool recognised across cultures, recognised across cognitive capacity as well. The other thing is with older people is language is such an important aspect. So actually talking with people or using words to describe, do you have mild, moderate or severe pain, is a lot easier for older people than a number scale. Next slide, please. So I've got an example here of some words that we can use that will help us assess pain. So for example, instead of asking if somebody is in pain, you could say, are you comfortable? If you're uncomfortable, is it tolerable or intolerable? Do you think your pain is getting worse or better? Do you feel like what we're giving you to help with your pain is enough or adequate? Are you able to do everything that you need to do, or is the pain stopping you? How did you sleep last night? And these are great questions for you to think about in your daily work as a conversation starter to try and understand if somebody is in pain and what the impact of that pain is. Next slide, please. The other really important thing with older people is that pain interference is probably more important than intensity. So asking somebody if they're in mild, moderate or severe pain is useful, but it's much more important to find out the interference or what the pain is stopping them doing. These are questions that are on the modified brief pain inventory, which I know some of you will have seen. And they're questions about, has the pain stopped you in the last 24 hours? Has it stopped your ability to walk, your general activity? And has it had an effect on your interactions with other people? So the way that pain is stopping people from doing things that they want is really important for older people. Next slide, please. One of the things that we need to remember is that pain is common in older people, particularly in residential aged care. And we know that there are high chances that the pain will be a combination of musculoskeletal pain potentially or neuropathic pain. And we know that around 1 in 4 people in Australia have some form of daily pain. And no, it's not just mums with headaches from their kids. It's actually a broader community setting. But for older people, we need to be very mindful of the sort of pain that that person might be in, because that then guides how we treat things. So for example, somebody with a diabetic neuropathy, so a neuropathic pain, might respond to different types of medication, probably not going to respond to opioids, but might respond to tricyclic antidepressant, low dose, or a gabapentoid or something like that, rather than an opioid. So it's really important to understand that pain occurs across the body, and there are different types of pain that we need to treat. Next slide, please. One of the things we want to do is always put our thinking cap on and consider pain as a reason for different behaviours, particularly with people who may not have or might be cognitively impaired in some way. Somebody who, for example, is all of a sudden aggressive or very moody, it could be a pain issue. So it's worth stopping and thinking and going, well, hang on a minute, what's going on here? Next slide, please. So everybody has a toolbox of things that they can do. Medications are a really useful tool, and I could talk for hours and hours about medications because I do love them. But it's also really important to remember a couple of other things. Repositioning is a great tool. So remembering that somebody might have been sitting in a chair or might have been sort of lying in a position in their bed. If you reposition and move their joints and limbs around, that can be great. Movement is fantastic. Any form of movement is really good for pain, and particularly musculoskeletal pain and things like that. Warmth is a great tool. A warm blanket or something like that can really help. The general rule with temperature and pain is if it responds to cold, it's acute pain, and if it responds to warm, it's probably persistent or chronic pain. That's a general rule. There's lots of things going on there. The other thing that I think is really important to remember is that all pain occurs in the brain, and if you can use distraction, it can be a really positive thing. Active distraction is much better than passive distraction. So if you have somebody playing a game or interacting with a video game or interacting in some way, that's a better pain management than just simply watching TV. Next slide, please. So movement is incredibly important. Pacing, not pushing people into pain when they move. Building and maintaining strength is incredibly important as we age. So get your OTs and physios involved, and get your people moving. Next slide. And questions. That's it. Questions.
So I've got a couple.
Yes.
You've spoken previously about the visual analog scale, so the faces.
Yeah.
The round faces not being as easily recognized as another shape.
Yeah, so they've done some research. Originally, when the faces came out, they were the big round circular faces.
Which is what we use.
Yeah, and look, they realised children particularly were afraid of the round faces because, I don't know why. But they also found that people couldn't perceive the scale as well if the faces, so then they came up with the thinner faces, which I happen to think look like aliens. I don't know, but and so those are considered to be more easily used. I have used both scale. I've used faces scales, and I have found that people just sort of don't really get where they should be on the faces. And that's why I tend to use the pain thermometer much more frequently, because it's easy tool. People understand, bottom is no pain, top is high pain, about middle. Like it's a pretty easy thing to do. Yeah.
And I guess if someone has a frontal type dementia, we're perceiving what other people's faces are telling them is a skill they lose. The faces would be unhelpful in that sense.
Anybody who has any neurodivergence, so ADHD, autism, anything on the spectrum, faces is not a useful tool at all. There's it's a really difficult thing. So I guess the main thing about tools is if there is a tool that someone likes, the patient or the resident likes, that they understand, just use that. Sometimes you have to go through, there are plenty out there. So that's the recommendation. Ultimately, if somebody's comfortable, they understand it, it's worked before, keep at that.
Yeah. And then I'm going to ask you one more question about the same context. So the tool that we use at the moment, I know that you're doing some work with us around reviewing it and enhancing its use in older adults. So we're very grateful for you for doing that. From a perspective of, so I think all of us have experienced that the numerical scale is problematic, because if you don't set it up properly, people will go, I have 15 out of 10 pain, and it's like, no, let's just go back to the 10. So you really got to set them up with what your worst pain ever was. And if you're living with someone or working with someone who's got cognitive impairment, that could be quite tricky. What do you think with the context of color, using color, like the traffic lights, green, orange, red?
Yeah, I think they're universal. Although I do think those sorts of things can be really useful. I think ultimately, though, pain assessment is really the best when it's a conversation. And so I do agree that symptom assessment ultimately is the best when it's a conversation. Are you comfortable? How's your breathing going? How's your anxiety levels going? How are you feeling? having that conversation helps you as a clinician really understand what it is what is the symptom that's the most important to this person right now, because they'll tell you what it is.
Yes.
And then how is it impacting on their ability to engage with their world.
Yes.
So, I think it's really useful. The tools that we have are really useful, but they're just tools. And so ultimately the conversation we have is the connection we want, so that we can then really come up with a plan together to, reduce the symptoms so it's not impacting on that person's ability to be who they are.
Yes.
Yeah.
So
I think that ties in really well with the SAS tool, in that we say the information you're going to get from that is only as good as the way you ask it.
Yeah.
And we sort of say you have to have it in a conversation. Otherwise, you're not going the information's going to be, they're going to become, they'll know if you're disengaged and basically sort of won't give you the information you need. But yeah, and the other thing that I heard you say, which ties in really well with the SAS, is in older adults, interference is the problem when it comes to pain.
Yeah.
And that ties back into the SAS, as in we say distress.
Yeah.
And we say maybe don't use the word distress. But what we're trying to find out really is interference. Like, how much is this symptom worrying you, bothering you, interfering with you?
100%. Saying to somebody, how did you sleep last night? How are you sleeping? That is a great way to start a conversation with how are you doing? How are you going? In pain management, a lot of pain services don't use the term pain. We don't go and say, how's your pain? We ask, are you comfortable? And those conversation starters are really, how are you going getting up out of the chair and walking? How's that going for you? Those.
Yeah.
I did see someone mention in the chat,
Yes.
they agree with the fact that pain is not always a useful word, particularly in the older demographic. There is that generation that don't want to bother the clinician or the doctor or whoever it is. Just if you're asking about pain, they can be quite stoic, but when you can break it down into a conversation like, how are you going, like walking around? I know you like to walk in the garden in the morning. How's that going? Like, if you can break it down into meaningful activities that they want to achieve in the day, it's really going to be very helpful for them to convey that information back to you.
Functional assessment is so important, and a lot of pain services in Australia and around the world now use a functional activity scale to assess the impact of pain and then the effectiveness of treatment on that function. So you're so right. Being able, are you doing the things that you want to be able to do, or is this pain stopping you doing that? And then you have to get you back to doing the things that you want to do. That's the real crux of it. Yeah.
And as clinicians, you go, Bronwyn.
Sorry, I was just going to say there's a question there too. So Pain Check uses the video that picks up on microfacial expressions of pain, and then adds the ABBY assessment tool into the assessment process, which is done as a manual process. The question here is, interested to hear, have you looked at digital pain assessment tools for non-verbal patients, including options like Pain Check? I have a comment to make as well, but you go first, Caroline.
So, Pain Check. I think one of the interesting things is Pain Check is no better than a trained clinician at observation is a tool that we use in many different sorts of groups of patients, in non-verbal adults, in non-verbal children and young children, those sorts of things. So there's a lot of observational tools that you can use that provide us with the ability to go, yes, this is what's happening. And I think one of the interesting things is Pain Check doesn't appear to be superior in picking up a pain than somebody who knows the person or is a trained clinician. So.
And I think, so my experience comes from a background of working with people with advanced dementia of frontal lobe disorders.
Yeah.
With the Pain Check relies on the facial expressions, but if people have frontal lobe type dementias or cognitive impairment, they often have very flat affects. So we struggled with Pain Check to pick up on the nuances on the face, facial variances that would have indicated pain was there.
Absolutely. Yeah. And look, I have worked in pain management and pain services for a long time. There are a lot of ways that micro expressions can mean something else. So I think it's important to put it always an expression, a human expression in context.
Yes.
What else is going on? You know, is there something else happening? So.
And sometimes the face, like I say, won't always pick up on changes, because you could have that very not much happening in the face, but you've got people dragging themselves up the corridor or constantly agitated. So one of the things I wanted to just say that, you know, you spoke about, as people get older, their experience of pain is much more severe. And then add to that the context of people living with an advanced dementia and who have got to the point where they're no longer able to self-soothe. So we speak a lot about, in our training, we speak a lot about how people can have increased psychomotor agitation. And we talk about that increased psychomotor agitation often comes from a pain background. And the thing that the staff really struggle with is because they go to the resident and they'll say, have you got pain? And, you know, this whole conversation is don't use the word pain, ask other questions. But then you have a group of people who have expressive and receptive dysphagia, so they don't understand the question. Then it comes back to what you were just saying about knowing the person and being able to tell what's changed, or recognizing that if they're pushing tables, stacking chairs, it's not normal behavior. And we should probably, and I'm hearing this from you, go to pain as the first reason that this change of behavior is happening.
Absolutely. And look, I think what's really important to understand is that if somebody, for example, can't tell you what's happening, or they can't understand, so we know we modulate pain inside our brain because we put an understanding around it. So if you go and sprain your ankle, you'll go, oh, my ankle hurts. And you understand why your ankle hurts, because you're doing something silly, like having too many white wines and wearing too high heels or something, whatever you were doing. Not saying that you do that, Bronwyn, at all, but I'm just saying.
You don't know.
You don't know. But when you understand why you're in pain, your brain turns down the pain. When you don't understand what's going on,
so true.
you don't have that modulation. So somebody who has you know, a dementia of any kind, they might not be processing why they're in pain, and that confusion actually exacerbates their pain. So the pain goes up. So that's really
even those without dementia, you know, as we age, we wake up each morning and with, you know, where's the pain coming today? And it's not always clear cut.
That's right. And that fear of movement, you know, you think, oh, I don't want to get out of the chair because my hip's going to hurt.
And that comes back to the multi-dimensional assessment of pain. It can't ever be one tool or just a conversation. It has to be a conversation. It has to be observation. It has to be watch how they're functioning and moving, and, you know, which does tie into assessing someone as a whole.
Absolutely.
PACOP has those tools. You know, we're doing the AKPS, we're doing the RUG. You know, we're asking them directly with the SAS. We're observing them with the problem severity score, with our clinical skills. You have to put it all together to come up with the best possible picture of what you're looking at.
And I think too, what's really important in tools, which is something you haven't mentioned, is our ability to advocate for the individual using a tool that helps our you know, fellow clinicians, our medical clinicians understand where a treatment needs to go. So if you've given somebody an analgesic and their pain is still high and you've used an assessment tool, it's an easy way for us clinicians to communicate with one another about what's going on as well.
Yeah, that's absolutely
right. There's a very interesting comment here about someone saying that a new resident was in a facility and the staff didn't really know her and they kept on asking if she was in pain, and she misheard them. And the question that she thought they were asking was, is it going to rain? So I think that's the other thing is, you know, we need to if we're asking those questions that you mentioned before about, are you comfortable? Can you get up okay? You know, is something stopping you from getting to the dining room? Those are questions that are better. There's another question here that says, can decreasing consciousness in a dying patient also turn up the sensation of pain?
I think the short answer is we don't actually know. So there's been a little bit of research around electrical activity and consciousness in dying people. But there is an assumption that at some point signals from the peripheral nervous system begin to degrade as you die, and therefore, you might not be receiving as much information from your peripheral nervous system into your central nervous system. However, I think the reality is the honest truth is we don't know. I would think that when people are moving in and out of consciousness, we know that there is a link. The part of the brain that processes pain in our central nervous system is right next to the part of the brain that processes fear. And so we know that when people are afraid and when they have high anxiety, that increases their pain. So I know I always speak to my patients. I worked in many years in intensive care with people who had fluctuating levels of consciousness, and I was always constantly trying to explain to them who I was and what was happening to them, with the idea that those two centers in your brain are very close, and so it's useful. The less fear you have, the better off your pain management is. That's the general rule. So that's probably what I would say around decreasing level of consciousness would be. There might be some issues around anxiety,
Actually escalating pain potentially.
Yeah.
We have some PACOP slides we probably just need to flick through. Would that be okay to just do that? I guess I'm just going to get Nat to talk to those quickly.
So we've just been told by our fantastic admin, we've only got a couple of minutes left, but really I think most of you in the chat are probably familiar with PACOP, and really all we wanted to do was just sort of highlight that, the whole purpose of PACOP is to screen people as a whole so that we can tailor their care plan to meet their needs at the time of assessment, and to make sure we bring in that assessment into a very regular and robust framework so that we know everyone's going to be assessed very regularly so we can pick up on anything, including the all-important thing of pain. If you just, like all of our assessment tools really incorporate pain, as we've already discussed. So we know obviously the SAS directly with that conversation, talking about pain as interference, making sure our conversation is as good as it can be so that we're getting the information that we're trying to about their symptoms. So that we know, obviously that's a no-brainer. Together with the problem severity score, pain is one of the domains because all important for everyone, particularly as we approach end of life. But the other tools we want to just tie in, which we have briefly touched on, is the AKPS, which monitors performance. Like someone, maybe even in conversation with the SAS may say, no, I'm good, I don't have pain, but you notice that, the way what they're doing in the course of a day has changed. Is that an indication that there is some sort of low-level pain there that they're not recognizing or not understanding or thinking it's something else? And same with the RUG, the RUG ADL. We're analysing what people do, how they can manage things that they do, in their daily living, and we're only looking at those last 4 at end of life, but still an all-important tool to use. We need to put together our information from all our tools together to sort of try to work out what's going on. We need to be detectives. Same with frailty. Obviously frailty, someone's had a fall, because their frailty risk increases with age. They have a fall, they're not going to come back to regular function. Pain is associated and woven through all of those tools. And then of course the phase, when you're dealing with outcomes, if someone's in an unstable phase because something needs doing, there's a good chance it's related to pain, whether that's in terms of medication, in behaviours, or changing what they need for their daily ADLs. It's just woven through the whole thing as it should be. So we just really want to encourage people. Thanks so much to Caroline, but to think of pain as a whole of body and a whole of PACOP assessment suite thing, not just contained to those two, the SAS tool and the problem severity score.
It's been so much fun having you, Caroline. And I think one of the things that PACOP is really grateful for is the ongoing relationship that we have with you, and then the work that we're doing together around a more appropriate pain scale for our population.
Yeah, no,
Thank you
it's
so-
fantastic. And thanks so much for having me. It's so nice to be able to sort of talk to people about, tools and what we really need to be doing, and it's lovely. Thank you.
Yeah, thank you so much.